Good morning. I'm going to get started with a couple of my projects that unfortunately were terminated. The patient satisfaction with early wrist mobilization after volar locking plate fixation of the distal radius fractures. We were having a lot of trouble recruiting patients. There was difficulty in follow-up, and we decided that it was not worth pursuing the study anymore. So we'll see if maybe in the future we can rework it and make it easier. And then we were going to write a case report about tungsten ring removal after hand injuries, but during our literature review, we found that there's already similar reports out there, and that it would be unlikely that we would add any additional benefit.
For the first study, what were the challenges? You said it was patient recruiting and patient follow-up.
So some of the challenges that we discussed at prior updates were that some patients were skeptical about taking their dressing down themselves post-operatively, which was part of the protocol for the people who were mobilizing early. And when we started the study, we didn't want that group of people to have to come in to the office to have their dressing change on post-op day 3 to 5, because it would add an extra office visit, which could increase their satisfaction regardless of whether the dressing's changed. So we didn't want that to be a confounding variable. And then it turned out that a lot of patients felt uncomfortable doing it on their own, especially because it's not our standard of care in our practice. And it's not something that, we tell patients this is the way we do it every time and it's always fine. And then there was also some smaller issues with just in terms of patient follow-up, getting them to come in for extra visits when normally we discharge them after post-op week 6. So I think that if we were to do it over, I would make it less about the early wrist mobilization and more about total care or total early care, where you come in at post-op day 3 to 5, you get your dressing changed, you see a therapist, you start working on exercises and see if the patients like that any better than just coming in on between days 7 to 10, get the dressing off, and then come back at week 6 and nothing in between. So we'll see. I have to put some more thought into it. This study is our evaluation of patient expectations and their outcomes after distal radius fractures. Anna and I are working on this together along with a bunch of our med students and attendings. We've recently, or I'll give some background for those of you who don't remember from last time. So there's a lot of interest in trying to understand how patients' expectations after distal radius fracture affect their outcomes, especially since we know now that elderly patients seem to do much better after these injuries, regardless of their treatment methods. So there's a measure used that's been validated in orthopedics called TEFTOM, which is trauma expectation factor and trauma outcome measure, that's been used to measure patients' expectations and compare them to their outcomes at different intervals in their treatment. For each one, you get the TEF survey is a 10-question survey scored 0 to 40 at your baseline when you first present. And then at each follow-up visit or at any particular follow-up, you can give them the TOM survey, which is similar questions, but based more on how your outcomes actually ended up. And then if you subtract the TEF from the TOM, it gives you their delta and shows you whether their expectations and outcomes were similar or higher or lower than expected. So we expected that patients overall would be able to more or less, match their expectations with their outcomes, but that people treated non-operatively and those over the age of 65 might be better able to match their outcomes with what they expected. And we aim to evaluate the patient's ability to do so, and then hopefully identify any disparities based on the patient age and treatment method. We included anyone with a distal radius fracture over 18 years old, and this is a prospective cohort study. It's not randomized. We took all comers with distal radius fractures and treated them in whichever way the attending physician felt was the best or most indicated treatment, and then separated them into their groups based on that. And then all of the surveys were collected via RedCap virtually, which has proven to be a very valuable tool for us. Broadly, we divided these groups into operative and non-operative groups, and then also did a post-hoc analysis on patients over and under 65 years old. We also collected a quick dash and a PRWE score at each visit or each survey. So at this point, we've reached over 50% of our goal for patient recruitment in a little less than a year. So hopefully by this time next year, we'll be done recruiting and close to having our final data set. We did an interim data analysis with our friends at Ruby's and found some interesting information already. And we just submitted an abstract to ASSH and probably will send one to New York Society for Hand also. This is just a quick view of our data so far. So some of the interesting things that we found is that all of the distal radius patients improved in their functional outcomes at 3 and 6 months compared to baseline, regardless of their treatment or age. But we found that patients, so far at least, that patients treated operatively were found to be able to more accurately estimate their outcomes at 3 and 6 months, whereas those non-operatively actually underestimated their outcomes, meaning that their expectations were lower than their eventual outcome scores. And then patients over 65 were found to more accurately estimate their scores, while patients under 65 also underestimated what their final outcomes would be. So I thought that was particularly interesting. And maybe it's because the patients that we're operating on were doing more work preoperatively to set their expectations than their non-operative patients. We're having longer conversations with them, consenting them for the procedure and telling them exactly what to expect. So we'll see if this continues to hold true when we get to our final number of subjects.
Todd, what do you think is your—
Todd, quick question. Go ahead, Charlie.
Go ahead.
Charlie, I'm saying, sorry, Todd. So what's your, for your patient report outcome measures, what is the kind of the longest time out that you want to record those for the purposes of the study and reporting? And are you seeing any trends towards those outcome measures plateauing if you keep giving the survey? At what point does it basically start to look the same at each time they take it? So what's your endpoint for follow-up on those outcome measures? And then do you get a sense of when they really hit their peak recovery?
Yeah, so we were debating whether to follow these people out to 6 months or 12 months. And we hypothesized, at least initially, that by 6 months, they'd probably be near their final results. And I think that the data so far shows us that that's mostly true, except for a few small exceptions. But the thing is, even if we could also, continue to follow these people out to 1 year. And if the data looks like it's not changing from 6 months to 1 year, we can stop, following them for an entire year and make the cutoff 6 months. So for now, we'll plan to send out another survey at 1 year. And, if we decide, if it looks like we don't need it, then we'll be able to wrap things up sooner.
That's great. It's really good study design. And I think the RedCap, like you said, is key for this. Nice job.
Yeah, it's been really great. And Bobby's been really helpful, and Joe Haas has been helping us with this one. So it's been going well. Right. So I'm just saying a lot of journals require 1 year follow-up. So that's another thing to consider.
And I think it'd be important to show that people are maxed out at 6 months, and that's something that would be beneficial to doctors to say, hey, at 6 months, it is what it is. So it's worth getting the 1 year follow-up for that reason. We know ankle fractures continue to improve up to a year. So it'll be interesting to see if the radius fractures are the same.
Good point. Yeah.
Todd, is that trauma expectation minus outcomes? Is that been used for other fractures or?
Yeah. So it's been used for other fractures. It's been used for ankle fractures. It's also been used for non-trauma or non-fracture cases as well. I don't have the full list with me, but it's been used in a bunch of different areas.
Very validated.
Yeah, it's been pretty well validated at this point.
Your study's moving along really well. I think you're doing a great job. What would you say is your one major challenge to having this continue at this pace? Because you're doing very well.
I think that the biggest challenge when we got started was just finding the patients and making sure they were noticed when they come in the office. And having a research coordinator has been really key for that, because he's able to monitor the patients coming in and see this person is coming in with a wrist fracture today. So he goes and talks to them himself and recruits them for the studies. So that's been essential. I don't think this is a study that we would have been able to do 2 years ago.
What percentage of your patients are actually enrolling? Do you know? You need to know that.
We don't have a number right now, but we can figure that out.
It's a good
Hey,
point.
Carlos, it's Brian. We're keeping track as if they decline participation. But of the people that we enroll, it's probably about 90% are willing to participate, because it just is some forms, and obviously the follow-up at the later time periods is a little harder, but we have Bobby calling them, or we can do it via. A lot of times these are old patients, the phone calls. So very few decline it in the office. The problem is we don't have a consecutive series, because at least for me, when Bobby's not here with me, I'm not enrolling patients because they just don't have the time to get done. So depending on which office he's in and which attending he's with for the day, those are the patients that are possibly enrolled.
Yeah, this study compared to other studies, it's been very much easier to convince patients to do it, because it doesn't change their treatment at all. And it's just a survey. It's just a matter of getting them to fill it out at follow-up.
Like Brian said, it's important also to know that's great. You enroll 90% of them, but what percent are finishing the whole series of questionnaires? Because
Right.
obviously self-selects a group
Right.
of patients that may not be happy. You don't know.
Right. That's something that is definitely important, but we don't know yet because we just haven't had enough follow-up yet.
Yeah, generally with surveys like this and follow-up, where you're doing it remotely and not in person when they're coming in for a visit, you can run into attrition of up to 70%. I think that's pretty well documented in anything you do. But it sounds like you've got the right mechanism to capture as many people as possible. So keep it up.
The good thing is we don't need them to come back into the office at all at any of these time points. So that makes it a lot easier. This next one, reduction techniques and volar locking plate fixation for distal radius fractures, is a project that I worked on with Dr. Monica and Dr. Cott, and Bobby and our med student Christina helped out. Basically, we noted that there's really not a good resource in the literature that summarizes as many as possible of the distal radius volar locking plate reduction techniques. There's a lot of reports of individual techniques in the literature, so we want to form a more comprehensive review for this. So we use a cadaveric model initially and performed as many techniques as we could find and think of, demonstrating on the cadavers with a volar locking plate. And we recently had this accepted as a review paper in techniques in hand and upper extremity surgery. And that one's an EPUB online, and we're waiting for the print. And then we just submitted it as a video abstract for ASSH, and we're waiting to hear if that gets accepted there. But we recently, this past week, took some intra-op videos of a distal radius ORF that we're hoping to combine with our sawbones and cadaver models to make a more comprehensive techniques video that we can either submit for as an abstract or on ViewMedi. And this is just one example of one of our videos. There's sound on this too, but it's not coming through, so you'll just have to take our word for it. So we have about like 3 hours of videos that we're going to parse down. This one is a case report that I've been working on with Dr. Chiappetta and Tom.
Hey, Tom.
Sorry.
The February 28th sort of tips and tricks symposium. You may want to send it there.
You got cut off there. You said OTA?
OTA, I think the deadline is March 2nd, I want to say, that they're looking for these sorts of tips and tricks sort of stuff. You may want to look at that.
Okay, we will. So this one is a case report I've been working on with Dr. Chiappetta, a patient who had an ALIF right before COVID and then was admitted to the hospital because it was felt that her cage had shifted and she underwent a revision surgery right after, right at the beginning of the pandemic. And she was suspected to have a COVID infection. Her husband tested positive, but people weren't getting tested at the time. And then she ended up getting much worse and had severe myelopathy appearing symptoms throughout her lower extremities. And after an extensive workup, ended up having multiple sclerosis and not lumbar myelopathy, or at least not lumbar myelopathy on its own. So we just finished up the case report for this and submitted it to Surgical Neurology International. So we'll see what they think of it. But a cautionary tale. And then another one with Dr. Chiappetta, where we had a patient who was referred to our office for cervical myelopathy and had pretty much no sensory or motor in her right arm and terrible cervical stenosis on her MRI. But she had a history of radiation to her right breast for breast cancer and had severe brachial neuritis actually from that radiation treatment that was caught before we pursued any further treatment for the cervical stenosis. So that one's also in progress. And then this one's one that we talked about previously, 2 cases of Wassel 7 triphalangeal preaxial polydactyly that we're just about ready to submit now. And we'll keep you posted on it. And then one that we discussed prior also, a case of distal intersection syndrome with one of Dr. Monica's patients had it bilaterally due to video game play. And then recently, Dr. Balicka also had one due to tennis, and it was almost identical findings on the MRIs. And Dr. Balicka's patient actually was treated operatively, and we have some good intra-op photos and path findings. So we're combining both of these into one case report. So it's pretty interesting. And then we have one study that we are planning on conducting, comparing 3 different surgical techniques for thumb CMC arthroplasties. This is Dr. Cott's, a study that he brought over from his prior experiences at Rothman. And, you know, the basic idea here was that we know that long-term, there's not been found to be any major difference between the different treatments for thumb CMC arthritis. But there's been increased interest in newer methods like suture suspensionplasty and internal brace. So we wanted to show non-inferiority of the newer ones and also see whether there are differences in the short-term outcomes, since a lot of people are doing these internal braces so that they could get people back to work or back to their activities faster. And then we also wanted to do a cost analysis based on the Medicare coding for each of these as well to see if there is a significant difference there. The inclusion was anyone over 55 with thumb CMC arthritis who had already failed conservative treatment, and they would be non-randomized into 3 groups: the trapeziectomy with or without the LRTI, internal brace, or suture suspensionplasty. And our primary outcomes would be range of motion, pain, and grip and pinch strength. And then we'd also be looking at return to work and activity and radiographic subsidence, as well as our cost analysis. So the IRB was approved for this study, both here and at Rothman, but we've had some difficulty in thinking about how to adequately power this study. It's not a procedure that's performed extremely commonly that we can get enough of these people in each group to have adequate numbers, especially because there's not a lot of people doing the suture suspensionplasty and there's less people doing the internal brace. So we'd likely have an abundance of LRTIs and be waiting a long time for those other groups. So we are still thinking about this one in terms of if we can make this work here. Not sure at this time.
It would seem you'd have to expand your study group to other institutions.
Yeah, so since we have the IRB at Rothman, that's something that we could investigate and see if anyone else there is interested. It's also challenging because it would not be randomized, because most of these hand surgeons have the technique that they prefer and are not willing to randomize into one versus the other, or one of the three. So that also reduces the power of our, or not the power, but the impact of our study. So still thinking about this one. And then nothing new to talk about right now, but some more coming in the next few months. Thank you.
What was the myelopathy brachioplexitis one? What was the teaching point or the take-home message of that paper?
The teaching point was that if someone comes into your office and they look like they have severe cervical myelopathy and severe cervical stenosis, that you shouldn't jump to conclusions and still need to do a full workup and pay attention to their history. Because, if we didn't know this person had radiation to their upper extremity, and we eventually got an EMG confirming that it was brachial neuritis, not coming from the cervical spine, could have ended up doing a huge surgery on her.
Is the myelopathy different than the plexopathy? Doesn't the myelopathy touch the lower? Is that affecting the lower extremity? Or are you saying their upper extremities?
Just upper.
We're having a little technical difficulty. We'll be right with you.
We got it. We're good. All right, good morning. Have a couple updates. First one is one we've been working on for a little while, is the direct anterior approach to the hip for a total hip using on a table. We have just reshot footage on multiple patients, I think towards the end of December. I'm in the process of going through that footage right now, which is taking a little longer than I expected. So I'm looking for any medical students with prior video editing experience to join me on this one. We have footage, pretty good footage from about 3 patients intraoperatively, and the goal is to kind of create a coherent video explaining the approach and the technique with kind of a voiceover and submit to either ViewMedi or Ortho Video Theater. Depending on how the video turns out, we'll we'll consider pairing it with kind of a larger chart review, but we'll see once we do final editing on the video, kind of what our next steps are.
What would the what's the chart review aspect of it? I'm trying to.
Well, so, it might improve our chances of submitting it somewhere, not ViewMedi is pretty a slam dunk. You can just submit it there. Sometimes if you pair it with Ortho Video Theater, there's options to submit it with a paper. And, if we have a good video coupled with really good data on a bunch of anterior hips, it might be something worth looking into.
That's what I'm asking, like what data though? It's like time of surgery, time to set up the patient.
Yeah, mostly time of surgery, dislocation rates, really kind of a deep dive into Dr. Kairos's mostly dislocation rates, I would guess. Yeah, it could be. Next one is called Utilizing Video for Preoperative Education in Meniscectomy Surgery. It's based off of a hand study that Dr. Cott and some others worked on that was recently accepted. It's basically comparing video instructions preoperatively for patients versus a paper handout. And the way it's set up is a randomized control trial where patients are randomized to either a video group or a handout group, and they're given the same set of instructions in different formats. And then we use kind of a patient questionnaire at the first post-operative visit to measure their level of knowledge in terms of the instructions. And the hand group showed that the videos increased the patient knowledge of opioid usage, as well as just overall in the video group compared to the operative instructor, the handout group. So right now, this is kind of part of the sports medicine research group, which I'll talk about in a minute. But I have a meeting with Rubies to discuss kind of the stats behind it, and then we're going to start on an IRB. The goal is to get any faculty, the sports faculty that do knee scopes and meniscectomies to participate in this. So we should be able to go through this project hopefully pretty swiftly. Next one is a relatively new project with Dr. Cott and some medical students on this as well, defining radial height and distal radius fractures, a confusing history. So basically the idea is that we've noticed that there's multiple definitions for radial height in the distal radius fracture literature. So we've kind of started a systematic review of the literature, doing a pretty broad lit review to identify the different definitions for radial height, where they kind of came up, and we're trying to figure out a way to prove that this difference can impact treatment decisions as it relates to distal radius fractures. So still somewhat in its infancy. We started to draft the manuscript, and we're continually kind of looking back at the literature. But we're hoping to get a submission to ASSH that's due at the end of February, but if not, certainly NYSSH and maybe some others. So that's kind of ongoing. Next one's a case report, locked knee and inferior patellar dislocation in an elderly patient. This was with Dr. Swan, kind of a unique case of an elderly patient with significant patellofemoral arthritis, where she had a superior patellar osteophyte kind of hinged in the trochlea. So she presented with a locked knee and patella baja, and then was initially closed reduced and immobilized, but then redislocated, requiring an arthroscopic debridement. So we submitted this project to JBJS Case Connector about 10, 11 days ago. So we'll see how that does. These are just some pictures from the case showing this lateral x-ray. There are a couple case reports of this out there, but no case reports where there's like a late redislocation after initially treating it closed. So this is the lateral x-ray, and then some fluoro images showing the osteophyte, and then the B is just the probe in the trochlear OCD. C is after debridement, and then D is when it's reduced. These are just more fluoro images showing the same thing, top row being the trochlear aspect, and then the bottom being the patellar. So I just wanted to bring this up. We've started a sports medicine research group over the last maybe 6 months, led by Dr. Gatt and some other residents, as well as some other faculty and staff at UOA. It's an interdisciplinary group that's been meeting every month, and we've really made a lot of progress. There's a lot of projects going on right now, and we're kind of in the stage where we're starting to recruit both residents and students. So these are kind of the list of some of the projects here, and I have more on the next page. What I'd like to do is, if there are any medical students interested in any of these projects that say pending next to them or have a blank space, you can email me if you're interested, and try to pick, if you're interested in multiple, place kind of a priority order on what you would be interested in, and then we can kind of start assigning medical students. For the residents, you can talk to me if you're interested in any of these projects. There's a good mix of kind of prospective studies, and then I also have some case reports and stuff after. There's a biomechanical study that Anjay is doing. And then there's really 2 of those. I know Jason Yang was interested in some of the benchtop stuff. And then these several are all pending IRB approval, and will need residents and medical students. These are the remainder of kind of the main projects that we've got going on. So there's kind of 10 projects that really are good projects and have a lot of steam. So if you're interested, just let me know. These are some case reports. I know Dr. Buckley just threw on a couple, meniscus root repair and the bilateral thigh compartment syndrome that need residents and potentially medical students as well. So.
Good morning, everyone. So first, I'll just talk about some things that I mentioned before that have since been submitted or accepted places. This first was a study with Dr. Cott and a few of the medical students here. It's been published in JHS Go. Our conclusion, or what we did in this, is we compared 105 hands, 84 of which had intra-articular steroid injection, and the remainder extra-articular, and we looked at outcomes following just to see how these patients did. We found that those who had intra-articular injection fared better at 3 months in terms of pain and function in patient-reported outcome scores versus those who had inadvertent extra-articular injection. That's been published. Our second study here, we looked at if steroid injection prior to CMC, arthroplasty, had any effect on, one, the outpatient reported outcomes, as well as on complications requiring antibiotics or second surgery. We found that there was no effect in patients who had the steroid injection prior to or who were steroid naive, and there was no. When we stratified patients who had fewer than 3 or more than 3, we saw no difference as well, and there was no difference in rate of complications either. The third is a study that is sort of it's looking into the way that what we did was we looked at students who had graduated and matched into orthopedic surgery from this program, and we did a survey looking at what they thought were the positives and negatives about their experience and things that they thought could be improved and areas in the institution's provision of resources, and identify the areas of strength and weaknesses was our goal. And so we kind of summarized their responses and kind of created small action plans in various areas in research and mentorship, et cetera. And we submitted this to the Journal of the GME. And then, and then the last two are chapters that were done with Dr. Tria in his book that he was writing, the Handbook of Musculoskeletal Medicine. Both discuss kind of a brief discussion of surgical intervention, injuries, surgical intervention and rehab in injuries in the pelvis, as well as the hip, pathology of the hip. So those are accepted, Bruce Bending. I'll sell you a copy when I get it. Next is an ongoing project. So next are ongoing projects. The first is a case report. Patient of Dr. Ishmael's that came in. This was a young patient who had a torticollis secondary to calcific tendonitis of the longus colli muscle, something he hadn't seen before and something that hadn't been reported in this age group. And so we thought it would be interesting to write a little bit about it and do a little bit of a review of the etiologies of torticollis, as well as sort of the progression of calcific tendonitis of the longus colli muscle. So we'll be submitting this shortly. It's written thanks to the help of everyone. Next is a study that I've spoken about previously. Just looking into the close reduction of fifth metacarpal neck fractures, sort of summarize our hypotheses and secondary hypotheses a little bit better than last presentation. And essentially, we just want to see if these are fractures that, one, stay reduced after being splinted. Two, if there's anything that we can see on radiographs pre-reduction that would let us know whether these fractures are going to stay or not. And at present, we got an injection of new cases from our colleagues in University of Radiology. The problem with that I've encountered that have been kind of slowly moving through is a lot of the fractures aren't technically fifth metacarpal neck fractures. And so we may have to review kind of our inclusion criteria. Next study here that I've presented in the past as well. Again, I've sort of clarified our hypotheses, variations in treatment of distal radius fractures. So essentially trying to understand what's driving the different treatment of distal radius fractures and what's causing us to treat non-operatively versus operatively. Is it training, patient demographics? Is it, and will what we see ultimately line up with what's in the literature or what's out now for the management of this fracture? So sort of a QI project in a sense, kind of understanding, are we doing things by the book? Are people behaving in ways that you'd expect? Are patients getting homogeneous treatment? So right now, the IRB for this study has been accepted, and we're nearly done with measuring all of the radiographs, and our friends in the Ruby's group have assisted us with understanding kind of the numbers of responses we'll need to have good power for our survey, or for our conclusions. Next is a newer one. Pardon the overlap there, but it's distraction-related complications after hip arthroscopy. So the last time I presented a study about hip arthroscopy was related to pre and or post-op rehab methods. In fact, there's been what I found was that there are pretty good and pretty recent systematic reviews for that topic. And so we discontinued that and we rebranded or changed the avenue that we're going down. And now we're looking into to figure out if different, essentially posted versus non-posted. So just to give a background, when you do hip arthroscopies, much like when you do hip nail, for example, on fracture table, there's usually a post through which you distract. Several surgeons more recently have tried postless distraction techniques using sort of traction against a pad or body weight and traction with a boot without a perineal post to access the hip joint for hip arthroscopy. And this study just wants us to see if there's any sort of, examine the different ways that physicians are doing postless distraction of the hips, and then understand the difference in soft tissue and nerve complications related to postless or posted hip arthroscopy. So right now we have upwards of 90 articles that we've seen that will give us some good numbers to compare both posted and postless hip distraction methods, and it's going well. Thanks, guys.
While Anna's preparing her presentation, I just want to say one thing, that our department research day will be Thursday, May 26th. Hopefully everyone will make the time to come in person for that. We're going to try to have, number one, we're going to have a poster session. A lot of the residents have had posters at national meetings. I think it would be good to have the posters up so everybody can see them and talk about them a little bit. And it'd be nice to bring the department back together to talk about some of the excellent efforts that the residents and students have done in research. So research day is usually AAOS Academy type presentations. They're less than 10 minutes with some discussion after each presentation. And this year, I'm speaking with Brian Cutts. Some of our students have done some work, and maybe a couple of the students may have some work that's ready for presentation as well. So we'll be inviting medical students as well as our residents to present on research day. So again, that's Thursday, May 26th. And it would be great if people could make the time to come to the school and promote some camaraderie in our department. Zoom is great. We have a lot of attendance, but it'd be nice to see everybody face to face for this one day.
All right, good morning. I have a few updates. My first project, which has been ongoing, was my COVID project evaluating the transmission of COVID following orthopedic surgery, which was done during the first wave. This was with Dan, Jules, and Dr. Sahabian, and a couple of very helpful medical students. We had submitted an abstract to EOA, which was presented, and it's going to be presented at AAOS next month. And our full manuscript, which has been done, is currently under consideration at Orthopedic Research and Reviews. This has been kind of discussed. It's just pending publication, this chapter on elbow disorders that several of the residents have worked on with Dr. Tria. This was a study that compared patient adherence with at-home hand and wrist exercises, which has been completed and published. And the next step is really just, we were planning to submit it to NYSSH for possible presentation. This was a study that I talked about last time as well, looking at ACell, urinary bladder matrix used for fingertip injuries. It was a poster that was presented at AAHS last month, and we had a small case series. We did submit it to PRS and injury, but because we had a small sample size, we only had like 12 patients, they recommended increasing our sample size, which we are still enrolling patients for. And we also eventually wanted to plan a randomized controlled trial comparing pure dressing changes with these distal fingertip injuries with ACell to see if there's a difference in recovery rates and functional outcomes. This next study is one that is also ongoing, looking at steroids. specifically a medrol dose pack in functional outcomes after hand injuries. So this was a study that Jason, several medical students, including Bobby and Usman and Dr. Kott, were looking at the use of a medrol dose pack after common hand injuries and looking to see if there's a difference in functional outcomes. We know that steroids have been used in other MSK injuries to reduce swelling and pain, and we have hypothesized that a similar result may be seen in hand injuries. So this study was basically just randomizing patients to a steroid taper or having nothing at all, and then looking at range of motion in the digits versus the unaffected hand, quick dash, opioid consumption, and pain scores at 3, 6, and 12 weeks, and then final grip strength, and then total time off work. Luckily, we just got IRB approved, so we're planning to start recruiting patients in the office soon. I foresee our biggest obstacle just being getting people to come into the office at 3, 6, and 12 weeks. And then it's going to be time consuming to get these measurements. And so, you know, having a research coordinator will be very helpful, but it will be time consuming. So, and then the last project I have is kind of in its still early development phases. It's underway. We're just thinking about looking at underrepresented minorities and several barriers to entering orthopedics. Like I said, we're still kind of teasing out what we want to specifically look at, but our research question for the time being was seeing when these exposures to orthopedics and MSK are. There have been some increasing reports documenting that minorities have later exposures and fewer exposures. And we wanted to look at why and how and where are these exposures coming from and how we can target it early, whether it's in medical school, which some of the other reports have looked at, and then, or if it's even before medical school. And there's some initiatives that have looked at trying to get women and minorities exposed to MSK medicine as well as engineering even before medical school to sort of spark their interest at an earlier time period. So as of right now, we're kind of that our research hypothesis is that you know, minorities will have later and fewer exposures to orthopedics and MSK medicine, and we're currently thinking about doing a survey type investigation. We were thinking about who we should send that survey to, and we're kind of thinking about doing looking at a list of applicants and potentially sending the survey out to a few years. If we can get a hold of a list of the past applicants for the past few years, or whether it's just MS4s and then first year residents, we're still teasing that out as well. But if anyone has any input or suggestions, very open to that. So we're still just in study design.
And are you including women as a minority or no?
Women, yes. We're looking at ethnic and gender minorities. Yeah, we have a
how are women minorities if they make up 50% of the medical school class today?
But they're minorities
They
in the field.
make up 10% of the orthopedic classes, though. Still.
So although we're not minorities, we're more minority just specifically within orthopedics. So we're just looking at like how ways we can target that and what the differences are if any exist.
That's why I brought it up. I think it's just a clarification point that the academy has a big push to get more women into orthopedic surgery. But, you know, as Dr. Kirschenbaum's pointing out, I think actually in medical schools, or some medical schools have more women than men.
Right.
So from a medical school class standpoint, it's not a minority, but from the number of people in orthopedic surgery, it's certainly